Welcome to The Explainer. Today we're diving into a clinical update on gender-affirming hormone therapy for adults. We're going to focus on the really practical stuff, the regimens, the monitoring, and the risk management strategies that you can take straight back to your practice.
So, to really get why these clinical updates are so important right now, you have to look at the bigger picture. This timeline just shows the incredible pace of change in India. I mean, we've gone from foundational legal rights in 2014 to dedicated clinics and training programs today. This isn't just abstract progress. It means more and more patients are seeking care, which makes having standardized, evidence-based protocols like the ones we're talking about absolutely essential.
Okay, so before we even think about writing a prescription, the WPATH Standards of Care 8 are our North Star. You're looking for a few key things. First, a gender incongruence that is both marked and sustained. Second, you have to be confident the individual has the capacity for truly informed consent. You'll also do a thorough workup to exclude other potential causes and assess any co-occurring conditions. And, this is so important, you must have a frank conversation about fertility, what the effects are, what their options are. Really, this isn't just a checklist. It's the absolute foundation for providing safe and ethical care.
Now, just a quick clarification on terms, because it matters. WPATH 8 makes a clear distinction between gender incongruence, which is the mismatch itself, and gender dysphoria, which is the distress that can come from it. It's a subtle but crucial difference. Remembering that not every person with incongruence experiences dysphoria helps us avoid over-medicalizing and allows us to create a truly individual care plan for each patient.
Okay, let's get into the nitty-gritty of masculinizing therapy. We're going to cover the regimens available and the key monitoring you need to do for your transgender male patients.
In India, we've got a good range of testosterone options. The standard is often injectable enanthate. But for more stable levels and way less frequent dosing, the long-acting undeconiate injection is a fantastic choice. And hey, not everyone wants injections, right? So for those patients, daily transdermal gel is great for steady levels. There's also an oral option, but you've just got to be prepared for more hands-on monitoring with that one.
When it comes to monitoring, our main goal is to get that testosterone into the target physiologic range. But the single most important lab to watch? It's the hematocrit. You'll check it at baseline, then every 3 months for that first year while you're titrating the dose, and after that, once or twice a year is usually fine. And of course, at every visit, you're keeping an eye on the usual suspects: lipids, glucose, blood pressure, and weight.
So what do you do when you see that hematocrit creeping up? This advice from Dr. Rothman is just perfectly direct and actionable. If it goes over 54 or 55%, you have a clear plan. First, work up secondary causes, then you can lower the testosterone dose, switch them to a gel formulation, which we know is linked with less erythrocytosis, or even talk about therapeutic phlebotomy.
This timeline is your best friend when it comes to patient counseling. It's so important for managing expectations. You can confidently tell patients to expect things like oily skin and their menses stopping within the first 6 months. But you also have to be really clear that the maximum effects, like, say, full beard growth, that can take 5 years or even more. Getting this timeline right builds a really strong, trusting relationship.
All right, let's switch gears to feminizing therapy. This is a whole different clinical picture, with its own set of preparations and, really, its own unique considerations.
With feminizing therapy, oral estradiol valerate is definitely a common choice. It's inexpensive and easy to get. But, and this is the critical takeaway for us as clinicians, it's all about the safety profile of the transdermal options. Both the patches and the gels have a significantly lower risk of venous thromboembolism, or VTE. And that's our #1 safety concern with any estrogen therapy.
And that VTE risk brings me to a few points that are frankly non-negotiable. First, you must, and I mean strongly, avoid ethinyl estradiol, the kind you find in birth control pills. The VTE risk is just way too high. For any patient over 45 or anyone with risk factors like smoking or obesity, transdermal estrogen should be your go-to. And remember, until or unless a patient has an orchiectomy, you'll almost always need an anti-androgen to get that testosterone down. Monitoring feminizing therapy is really a two-part mission. Goal number 1 is to suppress serum testosterone to under 50 nanograms per deciliter. Goal number 2 is to keep their estradiol levels in that sweet spot between 100 and 200 picograms per milliliter.
Oh, and a critical practice point. If you're using spironolactone as your anti-androgen, you absolutely have to monitor their potassium and creatinine. That's mandatory.
And here, again, managing patient expectations is just so critical. They'll start to see body fat redistribution and breast development within about 3 to 6 months. But we have to be crystal clear with them, estrogen does not change your vocal pitch. This is a super common misconception, and any patient who wants a higher-pitched voice is going to need a referral for specialized voice therapy.
Okay, so we've covered the basics of the regimens. Now let's zoom in on the most significant clinical risks that you're going to be managing across the board, specifically VTE and long-term cardiovascular health.
This brings us to the question that is, or at least should be, on the mind of every clinician prescribing these hormones. We all know VTE is a risk, but just how big is it really? And how much does our choice of estrogen actually change that risk? Well, this chart just lays it out in black and white. It's so stark. The VTE risk with ethinyl estradiol is just unacceptably high, almost 300 events per 10,000 person years. Oral estradiol is much safer, but look at the transdermal estrogen. The risk is nearly back to baseline. This data is the most powerful argument you'll ever see for a transdermal first approach, especially in any patient who has other risk factors. So if you put all the data together from a meta-analysis, the overall relative risk of VTE in transfeminine individuals is about 2.2 times higher compared to cisgender men. That is a clinically significant increase, and it really drives home why we have to be so careful with patient selection and risk mitigation.
And beyond VTE, we have to keep a lifelong focus on cardiovascular health. For every single patient on hormone therapy, this means we are doing diligent annual assessments for all the traditional risk factors: hypertension, dyslipidemia, diabetes, smoking. Proactive management here is absolutely key to their long-term safety.
All right, finally, let's touch on two crucial parts of long-term care that go beyond the hormones themselves. We're talking about cancer screening and bone health.
You know, the guiding principle for cancer screening is actually really simple and logical. You screen the organs that are there. For your trans women, they still have a prostate, so you continue prostate screening. They develop breast tissue, so you start mammograms based on standard guidelines. For your trans men, you screen whatever anatomy is left. If they had top surgery, you still check for residual breast tissue. If the cervix remains, they need pap smears. No hysterectomy, you have to screen for endometrial cancer if there's any unexpected bleeding. It's all about screening what's present. When it comes to bone health, there is one fundamental rule. Never, ever let a patient exist in a prolonged hormone-deficient state. It doesn't matter if it's from GnRH agonists or post-gonadectomy. If you suppress their endogenous hormones without giving them adequate replacement, you are setting them up for osteoporosis. This is why lifelong hormone therapy is so essential for bone density in any patient who has undergone a gonadectomy. And this all leaves us with a final thought to chew on. You know, as our evidence gets better and our protocols get more and more refined, this central challenge isn't going to change. It's always going to be this. How do we best merge these guidelines with the totally unique goals, needs, and lives of each individual patient sitting in front of us? And that, right there, is where the art of medicine will always meet the science.